Good afternoon, audience of the TCTAP 2025 30th anniversary. This is the wrap-up interview of the mitral and tricuspid intervention session. We had a great session with the distinguished speakers and panels, and now there are 3 interviewees with my co-moderator, Simon Lam from Hong Kong. And 3 interviewees is Shunsuke Kubo from Japan, and Shih-Hsien from Taiwan, and Gilbert Tang from US. And we had a 1.5 hour session with covering all aspects of the mitral and tricuspid intervention. It's really emerging the field, and many things are very rapidly changing, and those guys are at the cutting edge of the developing field. Let's move to the mitral valve session, and we will first talk about the mitral, and then we'll move to tricuspid. I have question to the Kubo. Yeah. Do you see the role of mitral tear is growing and expanding in Asian population? And what are the major technical challenges in treating the Asian people?
Thank you, Dr. Kang.
Yeah.
So I think now the mitral tear is a very important tool for the heart failure treatment, and also the global guideline recommended the class 3 level in both primary MR with a higher surgical risk and also the secondary MR. So in the Asian population, especially the patient have very small body and small heart. So the MTR is usually more easier for the very is enough space in the heart. So I think 2 factors is a very technical challenges. One is the size of the left atrium. The second is the size of the mitral valve. So when we treat the very small left atrium, we have to know to gain the height the septal puncture height to the mitral valve. So in the mitral clip device, so today, the Gilbert introduced the tips the toric to use the A knob. We have to use the A knob and turn the guide more posterior to gain the height. Also, another device, the Pascal device, it is more easier to gain the height. So this tips is very important to treat the small left atrium. Another is the mitral valve area. So, but now our group's Ocean Mitral Registry shows that there is no significant difference in the procedure quality and clinical outcomes even in the small mitral valve area less than 4. So it's a very important information for us, and also that it is important to use the small clip size small clip size for the optimal target position.
The excellent data from the Ocean Mitral is really valuable data there. And I'm really appreciated that you make the very good effort and make a very good publication to help the patient care. Yeah. Thank you.
Thank you.
Yeah, totally agree. So my question is to ask Dr. Song, and you're a very experienced mitral clip operator, and we always look at the imaging, the colors, but we always remind ourselves to back to basic, look at the parameters, and you highlight the importance of hemodynamic assessment in managing patients perioperatively for example, mitral tear. And first question, can you highlight what is the most important thing we have to take note on hemodynamic assessment? And second, how should a center to incorporate this kind of protocol into their workflows?
Yes, Simon, that is a really good question. I think to answer the question, we have to back forward to see which patient we are treating. We're treating patient with severe mitral regurgitation with heart failure symptoms. So actually we are treating heart failure patient. So as the old theory, we all know that for heart failure patient, two things is very important. One is the cardiac output, and the other is left ventricle and diastolic pressure, which can also be assessed by left atrium pressure. So in treating patients with mitral valve disease, we all know that procedure success by the valve criteria will be the MR can be reduced to equal or less than 2+. Now we pursue 1+, of course. And the other is we have to maintain the mitral pressure when equal or less than 4 millimeter mercury. So that is the fundamental idea. But sometimes when we have patients who have really complex mitral regurgitation, we probably are not able to achieve in both. We need to make trade-off between the residual MR and also pressure gradient. And therefore, I think the perioperative measure of hemodynamic would be very essential. You can either assess the left atrium pressure to be the guide. You can compare when you have additional clip and you further reduce MR and to see whether you have increase in left atrium pressure. I think that is also very essential. So I think in our daily practice, we actually seen our first patient. We have a swan gum continuous measure on cardiac output, and we also have placed another pigtail into the left atrium to also have continuous measurement in air pressure. I think when you have complete conflict in both index, residual MR, and also gradient, I think you can look in forward to the other hemodynamic parameter.
Yeah, I think this is a very important message. We have to advise new centers and everyone, don't forget the hemodynamics, because patient improvement clinically all based on hemodynamics, not the color on the echo, on the imaging. Yes. So thank you very much. So maybe you can go to the next question.
I want to ask one more question to Gilbert. Actually, I'm very honored of you for the excellent research activity and also the good perspective as a surgeon and interventionist. And I would ask some questions. One is that as you showed during the session, how do you streamline, how do you make easy the flow of your procedure? And is the experience as a surgeon help you more understand the procedure? And would you recommend interventionists to the experience, the surgical field or surgery? Yeah, that's my personal
I think
question.
it's very beneficial
Yeah.
for both surgeon and interventional cardiologists to work together in atrial ventricular valve, not just mitral valve, but tricuspid valve, because the intraoperative anatomy is actually very helpful to understand the quality of the tissue, the leaflet, especially in TEER technology, and also some of the more challenging anatomy for transcatheter mitral valve replacement or tricuspid valve replacement, because you can know the regional anatomy. In terms of workflow specifically for TEER, I think it's very beneficial for both the implanter and the imager to understand each other, to understand the device, and also both echo and fluoroscopic imaging, because as you know, these patients are typically sicker than the aortic stenosis patient. There are multiple comorbidities and, to Adam said, advanced heart failure. So we don't want to have the procedure under prolonged general anesthesia, which is right now required for these procedures. So we like to streamline the workflow, have the imager and implanter look at all the imaging modalities at the same time. So be able to quickly have the device steer and optimize the position to the target anatomy to be able to do either grasping or deployment, and also quickly assess the efficacy. And so you can rapidly make the decision. Right now, I think that is the key. And also, as you know, we have more advanced imaging now available, such as 3D intracardiac echo that help, especially in tricuspid side, to also help guide our decision making and also confirm the safety of the procedure. Because as you know, safety is number one of this procedure. Speaking as a perspective of surgeon, some of these patients are very high risk for surgery. So we certainly do not want to operate unless we have to.
Yeah, it's really the valuable opinion from your very special one, surgeon as an interventionist.
Yeah.
Thank you for your valuable opinion.
Yeah.
And shall we move to tricuspid?
Yes, I think the tricuspid valve is a good neighbor
yeah.
of mitral, but it's more complex because usually the valve can be fixed, but then leaving behind a lot of parameters, heart functions, right heart functions to us to take care of. So first question I would like to ask Shunsuke. So we know a tricuspid regurgitation is a big problem, and How often do you encounter patients with isolated TR? And if you plan for intervention, what is your strategy of screening those patients?
Thank you, Simon. So actually, in Japan, so tricuspid TR plan to be approved this summer. So now, we just started to screen the patient for the intervention. Actually, I think the 3 points are very important. One is, of course, the clinical symptoms. The second is TR grade itself. And the third is, I think, RV function. So I think the TR is for the torrential TRs, there is so much gap. And it's technically difficult for the TTR. So I think it is not suitable for the initial stage for TTR. And also, if the patient has a very severe RV dysfunction and the severe massive torrential TR, the intervention is a little bit late for these patients. So these 3 points, I think it's very important to consider the intervention.
Yeah, I think both clinical and anatomical feasibility. But overall, it's not to treat the patient too late, because when everything is burned out, the treatment may be have technical success, but overall clinical outcome may not be so desirable. Yes. So do we have a question to Adam?
Yes. Adam is actually my teacher. He supervised my first mitral clip procedure. Yeah. And now maybe the T-clip era will open soon, and I hope you teach me again.
Of course, my pleasure.
Yeah, and I've just read your excellent article on JAG Asia about the current status of the tricuspid valve intervention. Yeah, and as the primary author of the article, what do you think what is the most important issue to widespread the era of the tricuspid procedure in Asia?
Yeah, I think that's very important, given that the prevalence in Asia of TR actually similar as the reported in Western country. So the TR probably the most prevalent valvular disease in the world. So I think the challenge in the Asia Pacific region as well in Asia is that the availability of the novel technology to treat to do the tricuspid intervention, as well as the reimbursement system. Every country actually have different reimbursement systems, so the patients are not easy to get access of this new technology, whether it is repair or replacement technology is really costly. So I think, and also the availability would be a significant issue. I think that would be not only for the Asia Pacific, but also for some country, the developing country. So I don't know how to deal with that issue. I think it depends on if there are more and more, invented new technology. Probably the cost would reduce, and then that can, every country can available for those technology.
Yes, there are so many countries and so many different situations, and the totally different between East Asia and Southeast Asia, and also the South Asia and Middle East is totally different situation, and maybe we can concentrate on the Asia Pacific because it is TCTAP, and maybe you can teach me and other Asian operators to improve our skills. Can I just add one more practical question? And how do you frequently encounter patients with the residual severe TR after mitral TR procedure? And what would be the indication of the T-clip procedure on those patients?
Yeah, I think it's not uncommon, given from the reported data, almost 30% of the patients who underwent mitral TR procedure have a significant tricuspid regurgitation. Some of them would get significant regression in TR severity. There are some, I think we also learn from the surgeon, they have very good guidelines supporting that if the patient have more than moderate TR and also dilated tricuspid annulus. Even though the patient might not really suffer from TR-related symptoms, when they do the surgery, they will do concomitant tricuspid valve repair. So I think for the mitral patient who have concomitant TR, given that majority of the patient receiving mitral TR procedure already suggest them they are almost high surgical or even inoperable surgical risk. So I think the concomitant treatment might be feasible and reasonable for those patients who already have very dilated tricuspid regurgitation. In my personal experience, I will look for the tricuspid, not only the tricuspid diameter, annulus diameter, but also the pulmonary artery pressure gradient and also the coaptation. So if the patient have coaptation, tricuspid valve coaptation, but high pressure gradient related to the left side disease, so you can assess the right heart cath. If the patient are truly post-capillary pulmonary hypertension, which means that the increased pulmonary artery pressure is totally related to the left heart, which might be related to the mitral regurgitation. So when in those patients, if they have if they did not have dilated tricuspid annulus or they have borderline tricuspid annulus, I think after you abolish all the MR, the pressure, pulmonary pressure would went down and the TR, majority of them actually will get improvement. We don't need to really overemphasize the concomitant procedure, given that the TR per se actually is quite low surgical low risk procedure. So only for patients with already very significant elevated right atrium pressure, I'm afraid after mitral TR, we will have significant right to left shunt. For those patients, I was very aggressive to do the concomitant procedure. Otherwise, I think we can always wait and see the progression or regression of tricuspid valve.
Again, the comprehensive hemodynamic assessment is important. Thank you for your practical tips.
Yes. So, and also that sometimes for repeated procedure, you have to do another general anesthesia for the patient again. So I would like to ask Gilbert, because a new imaging modality, and for example, TE, we need general anesthesia, but sometimes, for example, after doing the mitral and going to tricuspid, what if we can do just under local anesthesia with eyes? And so the question is how the new imaging modality can help with the workflow of mitral or tricuspid intervention. And second question is, because availability is still an issue in the Asia-Pacific region, how would you recommend a new center, for example, in Asia country, to start a new program?
I would say first is get trained on imaging of both mitral and tricuspid valve, and we have very standardized workflow now for both valves to kind of learn how to image the both valves to get a comfortable. And then through that, I would say, they should partner with people like yourself who are experts to review. I actually do a lot of electronic review of images. I still remember my first proctoring of the tricuspid cases in the Middle East. We screened, I think, 20 cases when we picked like 3, because they are the most suitable ones at the time of the procedure given the new center. So I think it's very important not to tackle too difficult anatomy, but just pick the right anatomy and set yourself up for success. The also other important aspect, I would say, you have to keep the same team at least for the first certain number of cases to get the learning curve, because then you know each other's workflow, the personality and the dynamic, and so you get a good result every single time. And then finally, I think you're right that some cases you cannot do with TE because they don't have any imaging views appropriate for the technology. So you would have to use 3D intracardiac echo, which I think will be available in Asia very soon. And this is a game changer because we have cases where on screening, it was certainly appropriate with TE guidance. But then once during the procedure, when the patient's asleep under anesthesia, we could not see anything. Yeah. Maybe even just a transgastric view only. So because of those situations, then you have no option if you want to proceed to use intracardiac echo, because that's the only other imaging modality that you have to do the procedure safely. Otherwise, you have to cancel the procedure, unfortunately. So knowing when to not proceed, I think is also as important as when to proceed. So I think those are the learnings that I think we can all learn from each other.
Yeah, I think you also highlight, even we have very good device, communication within the team is very important, especially imager and the operator or within the operator to get a successful procedure and safe procedure. So thank you very much. Today we have a very good interview after the sessions and a very big topic on mitral and tricuspid, which is growing in importance in the world and also growing in popularity in Asia Pacific region. So thank you once again, Do-Yoon and Gilbert, Adam and Shunsuke. Thank you very much.
Yeah.